Medurstand. Understanding Medicine.
I'm Professor Aziz-ur-Rehman again, and today we are going to take up the next module, which is about the posterior wall infarction. Now, this posterior wall infarction is different than the inferior wall infarction. There was a time when there was some confusion, and we used to call it true posterior infarction just to differentiate it from the inferior wall infarction. Because heart isn't actually a very symmetrical structure, it is very hard to tell which part is the inferior and from where that part ends and the posterior part starts. So there may be little confusion, but the part of the heart which is opposite to the anterior part, that is called posterior wall, and if that part is infarcted, we call it posterior wall infarction. In older literature, the same is referred to as true posterior wall infarction. This is our curriculum, and we have covered all this, and this is the one we're going to take up today. Acute coronary syndrome affecting posterior wall, resulting in STEMI. So this is the topic for today. I'm Professor Aziz-ur-Rehman, working at Rush Medical College and also Senior Vice President, Pakistan Society of Internal Medicine. Just to revise our relevant coronary circulation, I'm not going to go into the detail. The posterior side is predominantly supplied by either left circumflex, this is the left main, and the left coronary artery divides into left circumflex, which just turns around and go to the back. It supplies the lateral side also, but for our today's discussion, it supplies the posterior side of the left ventricle. In 90% of the cases, the posterior wall of the heart is supplied by left circumflex. But in some cases, it may be the right coronary artery. You know, right coronary artery also goes and make a circle and goes backward. So in some cases, in 10% of the cases, this part of the myocardium, which we are going to discuss today, actually is supplied by the distal part of the right coronary artery. And the ECG leads which represent posterior wall, there aren't any, and these are the leads, precordial leads. They represent anterior wall and lateral wall. But if we place additional leads in this position, V7, V8, V9, they would represent the posterior wall. But there is a technical difficulty. Number one is that our standard ECG machines, they do not have additional leads. And the second one is when ECG is recorded, patient is lying back on his back, so it may not be easy to place electrodes here. So the solution is, and many times when you see the ECG, you don't have the patient in front of you. So I think the best way is to look for opposite changes of infarction, which we have learned so far. I'm going to revise them again. So we will look for the opposite of ECG changes in opposite leads. So opposite leads are these V1, V2, V3, and opposite changes would be ST depression instead of ST elevation, T wave, upright T wave instead of T wave inversion, and an R wave instead of a Q wave. This will be explained again. This we have discussed, but again, this is the infarcted part. In today's module, we are talking about the posterior wall. So if there were any posterior leads, they would show these changes: ST segment elevation, T wave inversion, and Q wave. But since there aren't any, we are going to see the changes, the opposite changes in the opposite leads. And in this case, we are talking about V1 to V3, and the changes would be just opposite: ST depression and a prominent R wave and an upright T wave. So these are the leads, and true posterior is not represented by any leads, but we will see the opposite group of leads and we will look for opposite changes. For example, we will focus on these three leads and look for the opposite changes. This is the infarction developing and causing ST segment elevation, but we are going to concentrate in the reciprocal changes in the opposite lead and these ones. So we'll be looking for these changes. Normally, we look for ST segment elevation in the corresponding lead, and in this case, we will look for ST depression in the V1 and V1, V2, V3. Normally, we look for T wave inversion, but here we would see upright T wave, or maybe in fact prominent T wave. Normally, we have Q waves as a different sign of infarction, but in posterior wall infarction, you may have prominent R waves, because if there is no Q wave and the existing R wave becomes taller, that will make it prominent R waves. They will just evolve like normal changes of infarction evolve. Now, this is the example. Somebody, high risk patient like smoker, diabetic, hypertensive, obese, sedentary lifestyle, family history, or whatever, comes with chest pain in posterior wall infarction and inferior wall infarction. Symptoms are likely to be more atypical. Pain may be only in the back, pain may be only in the epigastrium, and it may be confused with abdominal pathology. So you remain vigilant and keep this differential diagnosis in your mind, especially when you're not going to see ST segment elevation. So this diagnosis is actually easily missed by inexperienced people. So there is no rhythm step in this case, but just see the limb leads 1, 2, 3. AVR, AVL, AVF. What do you see? Do you see any problem, especially ST segment elevation? I don't see any ST segment elevation anywhere. Do you see any T wave inversion? I don't see any T wave inversion. Do you see any Q waves? I don't see any. But let's now examine the precordial leads. V1 shows ST depression. V2 also shows ST depression. V3 also shows ST depression. In fact, V4 also shows ST depression. So V1, 2, 3, and V4, they're all anterior leads. All of them, they show ST depression. If you see the T waves, it is certainly not inverted. This one, it is certainly not inverted. In fact, it looks as if it is slightly prominent, at least upright. So you have ST depression and upright T wave in the anterior leads. This could represent ischemia of the anterior wall also. But in this case, most probably it indicates true posterior or posterior wall infarction, because the history is suggestive of infarction. Resting pain, which is prolonged pain, which is associated with diaphoresis, should suggest to you the diagnosis of actual infarction, not just anterior wall ischemia. ST depression in right-sided leads can also be seen in right ventricular infarction, but we don't see any findings of right ventricular infarction. If you go further, there is no ST segment depression or elevation. T wave is also upright. So I draw your attention to these ST depression and prominent R wave. So I think the diagnosis is posterior wall STEMI, especially in view of the history. Of course, this patient would need troponins for final confirmation. So the criteria of posterior wall infarction are ST depression, prominent T wave, and tall R wave if this is slightly older, and in this case it is perhaps very acute phase, and you see these changes in precordial leads V1, V2, V3, and V4 in this case also. So these are the criteria of posterior wall infarction. What is the culprit artery? We just learned that posterior wall is mainly supplied by left circumflex, but in 10% of the cases it may be supplied by the right coronary artery. So you can only be sure by 90%. So 90% chances are left circumflex, 10% chances are right coronary artery, and final judgment, of course, will be made on angiography. All these patients should theoretically undergo an angiography. So this is just a guess. The final diagnosis will be made on angiography. This is the left circumflex. It goes back and somewhere here, because there is no lateral wall infarction, there are no changes in 1 and AVL, so lateral wall is spared. So I think left circumflex, not proximally, it is probably occluded slightly distally. That is why the lateral wall is spared, the posterior wall is infarcted. This is another ECG, just the revision. 1, 2, 3, AVR, AVL, AVF, no changes, but V1, V2, V3, not V4, they show slight ST depression. You can see the ST depression here, at least it is quite prominent. And you also notice prominent T wave here. You notice prominent T wave, upright prominent T wave. Not very significantly prominent R wave, because again it is perhaps a relatively acute infarction. So this ECG again in the proper context should be interpreted as posterior wall infarction, posterior wall STEMI. Troponins would be definitely needed for final confirmation. Posterior wall ST segment elevation. I say acute coronary syndrome because in this type of ECG, it is usually not possible to be 100% sure unless you have documented elevated troponins. So at this ECG, we should call acute coronary syndrome. And once we receive the report of troponins showing elevated troponins, that will confirm the diagnosis of posterior wall STEMI. Criteria: ST depression, prominent T waves and tall R wave in V1 to V3. Okay, so this was posterior wall STEMI. Culprit artery, 90% left circumflex, 10% right coronary artery. Thank you very much. This was Professor Aziz-ur-Rehman and we covered posterior wall STEMI. Please join me in my other videos, and channel is free and we have many topics other than ECG, so I would really like you to see me on my other YouTube videos. Thank you very much.